Namaskar dosto, good evening friends. I am Dr. Sanjay Kalra, your friendly and familiar endocrinologist. And you're watching Dr. KK's Med Talks, Mondays with Dr. Kalra का non-stop show का 1111 1111th एपिसोड है. तो एक स्पेशल शगुन वाला दिन 1111वां एपिसोड है हमारा. इस शगुन वाले दिन पे let's have the headlines for today. Obesity rates are expected to soar amongst children and adolescents, and by the year 2050, it is expected that at least 1 out of every 6 children and adolescents will be living with obesity. तो ये बहुत बड़ी महामारी की तरह ये हमारे सामने आ रही है ये बीमारी. In child obesity clinics, which see patients with only BMI over 50, मतलब इतना ज़्यादा BMI, severe obesity, morbid obesity के साथ, उन्होंने ये पाया that 24% of all such children have autism, 23% have a learning disability and 30% have liver disease. तो जो obesity है वो और बीमारियों का घर भी है. There is a very important link between screen time and body weight. तो जितना ज़्यादा स्क्रीन टाइम या स्क्रीन एक्सपोजर होगा उतनी ज़्यादा ओबेसिटी होगी. एंड उसके साथ और लिंक आ रहा है बच्चों में विद स्पीच एंड कम्युनिकेशन प्रॉब्लम्स. तो जितना ज़्यादा समय आप बिताएंगे स्क्रीन पे उतना ही ज़्यादा ओवरवेट और उतना ही ज़्यादा इश्यूज विद कम्युनिकेशन एंड स्पीच. Yet there is good news as well. तो स्टडीज ये भी कहती हैं that access to healthy food early in life, यदि आप सही खाना या तंदुरुस्त खाना आपको मिले बचपन में, किशोर अवस्था में, that can lead to improvement in health later on in adult age. तो जो आप बचपन में खाएंगे उसी से पता चलेगा कि आपकी बड़े होके सेहत कैसी रहेगी. And in some parts of the country, there is still a difference between rural obesity prevalence and urban obesity levels, though it is reducing fast. गांव में जो बच्चे हैं वो obesity का शिकार कम होते हैं. This is in spite of having the same genes that their friends have in the cities. अब इस हेडलाइन के साथ आज के टॉपिक पे जाते हैं और आज का टॉपिक देखते हैं क्या है. अरे वाह, इतना सिंपल सरल टॉपिक बट इतना इम्पोर्टेंट. ओबेसिटी इन चिल्ड्रन, इम्पॉसिबल टू मिस. इससे सिंपल टॉपिक क्या होगा और इससे ज़्यादा इम्पोर्टेंट टॉपिक क्या होगा. आज का फिर गेस्ट इंट्रोड्यूस करते हैं जो बहुत ही सिंपल साधारण से एंडोक्रिनोलॉजिस्ट माने जाते हैं पर बहुत ही इम्पोर्टेंट है और पढ़ाई में अव्वल, काम में अव्वल. ये है हमारे लिए डॉक्टर शुभांकर चैटर्जी. वार्म वेलकम सर.
Sir, thank you, sir. My best regards for you and all the audiences out there. Thank you, sir. Thank you, sir,
Thank you,
inviting
Dr.
me.
Subhankar. Yeah, and to introduce you to everyone who is logged in, Dr. Subhankar is a senior resident in the Department of Endocrinology at the prestigious Medical College and Hospital, Kolkata. An MD in Internal Medicine, a DM in Endocrinology, his academic and clinical journey reflects a passion for learning, for education, for Saraswati. इनका जो खास फोकस है वो है द इंटरप्ले बिटवीन एंडोक्रिनोलॉजी एंड न्यूरोलॉजी. और एक सब्जेक्ट है हमारा डायबिटिक स्ट्राइटोपैथी, ग्लाइसेमिक ब्रेन इंजरी. जब आप नेट खोलते हैं और जब आप पबमेड पे देखते हैं कि आर्टिकल्स क्या हैं तो उसमें सबसे ऊपर डॉक्टर शुभांकर का नाम आता है अपने दोस्तों और अपने कलीग्स के साथ. इन्होंने बहुत मेहनत की है और उन्होंने बुक चैप्टर भी लिखा है डायबिटिक स्ट्राइटोपैथी पे. तो ये ग्लोबल हमारे एक्सपर्ट हैं एंड वी आर वेरी प्राउड टू हैव यू एज डॉक्टर चैटर्जी.
Thank you, sir. Thank you for your kind words. You have always been a mentor for me since 2012. Thank you, sir. Thank you, sir, for being there in difficult times.
It's great to be with you. And Dr. Subhankar, we have greetings for you from all over the country. Anita Dadlani madam, Rekha Bhattara ji जो दिल्ली से हैं, Swapna madam वेलोर से, तमिलनाडु से, and Ram ji Agarwal साहब all greeting you. And before we begin with our topic, which is obesity in children, Agarwal साहब has a question for you. He says, does palm oil intake or refined oil intake directly lead to increase in cholesterol levels, in LDL levels?
Yes, sir. Yes, sir. Palm oil is actually there's a mix of fatty acids, but predominantly there is saturated C16. Palmitic acid is the predominant there. So high emission of the palm oil may actually can lead to increased bad cholesterol. This LDL. LDL maybe get higher up with increased use of palm oil.
तो एक्चुअली ये बढ़ता है, पाम ऑयल से एलडीएल भी, ट्राइग्लिसराइड भी बढ़ते हैं। इट्स इंपॉर्टेंट बिकॉज व्हेन यू गो आउट टू बाय अ फ्रोजन डेजर्ट, आप आइसक्रीम खरीदने जाते हैं, तो कभी कभी आपको आइसक्रीम मिलती है जो दूध से बनती है, बट ज्यादातर आपको फ्रोजन डेजर्ट मिलेगा जो फ्रोजन पाम ऑयल से मिलता है. So let's ask everybody, while Dr. Subhankar talks about obesity in children, let's ask everybody, कभी ऐसा हुआ आपके साथ कि आप गए आइसक्रीम खाने, आपको लगा कि आपने आइसक्रीम खरीदी है, बाद में जब आपने देखा लेबल तो उस पे लिखा हुआ था जी ये तो पाम ऑयल खा लिया मैंने, which was a bit unhealthy, on the unhealthier side.
Yeah, yeah.
So, Dr. Subhankar, greetings for you also from Dr. Shivlata Chatterjee, madam. She is a physician in Delhi, and Vinayak Sharma ji. So, the question that everyone has for you is, why have you chosen this topic, obesity in children? Why is it important for us today?
सर, सबसे इम्पोर्टेंट बात तो ये है कि हम लोग जिस समय पीडियाट्रिक एज ग्रुप या एडोलेसेंट एज ग्रुप में थे, हम लोग बहुत दुबले-पतले थे। शायद 10 फ्रेंड्स खेल रहे हैं, तो उसमें शायद एक एक फ्रेंड है जिसको देख के थोड़ा ओवरवेट या ओबीस लगता था। And but now when I come across today's generation, when they play the outdoor games, I just uh, came was coming back from a hospital and came across the playground. I was observing that out of 15 children, there was at least 6 to 7 who were actually overweight or frank obese. एकदम देखने में ही आपको सर लग रहा है, तो दैट इज अ वेरी अलार्मिंग थिंग टू हैव. एंड childhood obesity will actually translate to adult obesity if not prevented at that point of time, and will lead to much more hazard regarding the NCDs, non-communicable diseases like type 2 diabetes, hypertension, and metabolic syndrome. So it should be prevented at the earliest possible time. So I think this is an extremely important topic, not just for treatment but for the prevention as well.
तो अगर ये इतना महत्वपूर्ण टॉपिक है, so Dr. Subhankar, if it is important, would you like to take us through this topic? Perhaps we can learn
Yes.
about the basic science, uh,
Yes.
why it occurs, what we can do about childhood obesity, and then we take questions from everyone in the audience. So over to you,
Bilkul.
Dr. Chatterjee.
Yes, sir. I will try to make simplify the topic, and will try to be brief as possible, although it is a very vast topic still. Now, in
We have a
introduction, sir.
request also for you from we have a request for you from a listener in Tripura who says कि सर आप इंग्लिश और हिंदी में तो समझाते ही हैं हमेशा, बट आप हमें बंगाली में भी समझाएं साथ में. So that request is coming from Tripura.
I will do it, sir. I will do it, sir. Yeah. So, sir, the thing is that childhood obesity is such a condition that if the child if those who has it, actually there is a proneness to be stigmatized in the society, particularly in the school or in the playground by his or her peers. Now, पीडियाट्रिक ओबेसिटी एक कॉम्प्लेक्स डिजीज है जिसमें जेनेटिक, मेटाबॉलिक, सोशल फैक्टर, चिल्ड्रन का बिहेवियर, पेरेंट का बिहेवियर, एंड ऑल्सो देर आर सर्टन एनवायरमेंटल contributors as well. Now, post COVID, the whole environment, the whole world is actually has become more obesogenic than ever. And as I was talking previously, कि pediatric obesity will actually translate into adult obesity and lead to more and more non-communicable disease burden if not prevented at this earliest stage. तो पहले हमको तो जानना है कि हम लोग ओबेस क्यों होते हैं, तो उसके लिए हमको जानना है कि हंगर क्या है और सैटिस्फैक्शन क्या है. तो हंगर में हम लोग दो टाइप का हंगर होता है. एक है होम्योस्टैटिक वेट रेगुलेटरी सिस्टम, जो आपका एक सिग्नल that rests in the hypothalamus or the brainstem that signals about the weight regulation around a particular body weight set point. Another thing is the hedonic hunger, hedonic system. ये आपको प्लेजर ड्रिवन करता है. hedonic system of hunger actually resides in close association with the addiction circuit, like the sugar addiction. So the hedonic hunger and also the homeostatic hunger, both when they gets dysregulated or disinhibited, then actually there is more and more intake, more and more hunger and less satiety, leading to obesity. Now, दिस इज अ बिट ऑफ कॉम्प्लेक्स थिंग कि हम लोग का कुछ सिग्नल्स है जो ओरेक्सिजेनिक है और कुछ कुछ एनोरेक्सिजेनिक है. ओरेक्सिजेनिक जो है वो आपका जैसे ग्रेलिन है आपका स्टोमक से जो निकलता है, एक न्यूरोपेप्टाइड वाई, ओरेक्सिन, ये सब. और side by side there is also anorexigenic agent as well, like peptide YY, CK, cholecystokinin, pancreatic polypeptide, MSH, etc. Now they actually works in a very tandem way to regulate the feeding center in the brain, in the hypothalamus. Now, another system is very important to know, the leptin melanocortin pathway. Why it is important? Because there are certain disorders, monogenic disorders, they occur due to the mutation in this pathway, in the gene in this pathway. Now, and also we're targeting drugs, newer drugs which are actually targeting these pathways. Now जैसे सर बोल रहे थे कि एपिडेमियोलॉजी के बारे में थोड़ा, तो ये बोलना चाहेंगे कि हम लोग का इंडियन डेटा क्या है. पर्टिकुलरली हम लोग अगर इंडियन डेटा देखेंगे कि ऑल ओवर इंडिया post 2010 there is 19.3% prevalence of childhood overweight and obesity, and in the last decade it has actually nearly doubled. Now, as Sir was telling that what are the risk factor for the Indian children, particularly the being boy from urban population, higher social status, and sadly, the North Indian population are particularly at risk of obesity. तो हम लोग ओबेस क्यों हैं, उसको तो बहुत सारा कारण है, लेकिन जैसे ये सिर्फ एक पेशेंट का चीज नहीं है कि जस्ट ओनली द पेशेंट इज द ओनली रीजन व्हाई ही और शी बिकमिंग ओबेस. दिस इज आल्सो important national factor, like importance in the policy making, like marketing of unhealthy foods, uh, lack of proper scientific food packaging or food labeling. Also there is community factors, like how the environment of the school is, how the environment of the family is, how much time the child gets to play, or whether there is enough space in his or her location, कि एक खुला माठ है कि वो थोड़ा आउटडोर एक्सरसाइज कर सकते हैं. हम लोग के टाइम पे ये it was ample space to play football or cricket. Nowadays, very sadly that the space is day by day is becoming shortened. Now, also there is individual factors. Here lies the genetic factor. Number one. Number two is the obesity of the father or mother, their feeding behavior, maternal weight gain during pregnancy, maternal diabetes or GDM, and even after taking birth, whether the patient is being breastfed or not properly, at least up to 6 months, is very important deciding factor, the childhood or even adult obesity. And also whether there is introduction of early formula feeding, this is also very very important. Now, as I was discussing the important parental factors, number second is that this cartoon is showing the depicting the classical predation hypothesis, how obese mother can lead to the childhood obesity in her uh, infant. Now, as I was discussing the postnatal nutrition during the school age years or during adolescence, their physical activity, as Sarah was mentioning, the screen time, extremely important, and also the sleep hygiene, quality of sleep, duration of sleep is extremely important in determination of the childhood obesity. Now, types of obesity. Now, most खास खास जो हम लोग देखते हैं, सब থেকে कॉमन যেটা আমরা দেখি যে exogenous or constitutional obesity, আমরা অনেক সময় এটাকে বলি simple obesity, but this is actually not simple, because although it is termed as simple obesity, but it is actually having a far reaching or complex interplay with the metabolic health of the child. Now, second is monogenic obesity, like single gene disorder, like the most commonly the MCR4 mutation. Another group is syndromic obesity, like Prader-Willi, like Alstrom or Cohen syndrome. Number four is hypothalamic obesity. That is particularly we see post surgery of a tumor, or particularly in case of craniopharyngioma, or hypothalamic infections or other SOLs. Now, certain drugs, particularly those used in the as antipsychotic, antidepressant, antiepileptic, are also important contributor of drug-induced obesity. And last but not the least, the endocrine causes of the obesity. That is a true endocrine cause, or you may say those are actually however the less than 1% of the total obesity, but they should not be missed, like Cushing syndrome, growth hormone deficiency, pseudo hyperparathyroidism, or hypothyroidism. Now, these are the genes in monogenic obesity. ये बहुत ही जनरल पब्लिक के लिए उतना इंपॉर्टेंट नहीं है क्योंकि ये अनकॉमन है अगेन, बट कैसे हम जानेंगे कि ये मोनोजेनिक ओबेसिटी है? कि अर्ली ऑनसेट ओबेसिटी, सीवियर ओबेसिटी एंड एक्सट्रीम हाइपरफेजिया आर द क्लूज फॉर monogenic obesity. These are the genes implicated in the monogenic obesity, and there are certain clues in the clinical feature from which we can pick up exactly which gene is being involved. Now, these are the examples of the syndromic obesity. ये क्या है कि मल्टी सिस्टम इन्वॉल्वमेंट विथ डिस्टिंक्ट फिजिकल फीचर्स. हम लोग आउटडोर में एज एन एंटरप्रेन्योर देखते हैं कि Prader-Willi syndrome is a particularly important example in this category. Now, I am just not going through this passing through these slides that not that much of important for public education. So the next is I was discussing the hypothalamic obesity. I have already discussed it. Now the classic endocrine disorder. Now the very important to know for physicians or pediatricians is that कि अगर in simple obesity the height is not faltered. Actually, the obese child, due to various reasons, particularly increased insulin, increased leptin, there is never a growth failure. Rather, patient actually may be in higher normal or even tall. When there is short stature or growth failure is prominent along with obesity, we should not miss these classic endocrine disorders. Now, as I was discussing, the drug-related obesity, and also now going to the clinical approach, how should we approach the patients? Now, पहला चीज ये है कि ये ओबेसिटी एक्सोजिनस और सिंपल ओबेसिटी है कि इसके अंडरलाइन कुछ सेकेंडरी कॉज है. नंबर वन. नंबर टू इज हाउ टू ग्रेड इट, हाउ टू स्टेज इट, एंड देन कम टू द management. Now, when grading or classifying obesity, is that it's slightly different from adult to than children. So in overweight is defined as when BMI is more than equal to 85th to less than 95th percentile. Class 1 obesity is BMI more than equal to 95th percentile to less than 120% of the 95th percentile, or BMI more than equal to 30 or to less than 35, whichever is lower. Now, इसी तरह क्लास 2 है, क्लास 3 है. Numbers, then apart from grading, there is obesity staging. Now, grading का आपको बोलते हैं कि according to BMI हम लोग पेशेंट को क्लासिफाई कर रहे हैं. नाउ स्टेजिंग, हाउ सिक द पर्सन इज. यहाँ क्या करते हैं कि पेशेंट का along with the BMI we take the medical, mental conditions and also the functionality of the patient. According to that, we further stage the obesity. Now, while taking history of a patient, of a child with obesity, it is important to know the following things: maternal weight gain during pregnancy, diabetes in pregnancy, maternal and paternal weight. As I was discussing, that actually the all these things are risk factors for the infantile or childhood obesity. Both low birth weight and macrosomia are associated with the obesity later on. And postnatal history is extremely important, whether the patient was breastfed or not, if we are breastfed, how much duration, whether early formula feeding was started or not, any history of hypoxic ischemic encephalopathy, any early introduction of antibiotics. These are also very important to note. Now, ये है बहुत इंपॉर्टेंट है कि ग्रोथ पैटर्न कैसा है. जैसे हम बोल रहे थे कि ग्रोथ पैटर्न जानना क्यों इंपॉर्टेंट है. पर्टिकुलरली अगर ग्रोथ आपका बच्चा का नहीं हो रहा है, साथ के साथ बच्चा आपका ओबीज भी है, तो आपको एंडोक्राइन कॉज सोचना ही सोचना है. एंड ऑल्सो ये एक इंपॉर्टेंट है कि हाइपरफेजिया एंड फीडिंग बिहेवियर, ये भी इंपॉर्टेंट है क्योंकि hyperphagia is particularly important to a very important clinical clue for monogenic obesity. The pubertal status of the patient. Delayed puberty is actually occurs in association with the syndromic obesity. And simple obesity, usually puberty is not delayed. In certain cases, particularly among the girls, it can actually be advanced. Now, socioeconomic status, the family history, the diet, extremely important. Frequently missed in the busy OPD, but diet should be properly calculated. And it is a very common for the patients to deny that the child is not taking excessively, but proper calorie calculation, thorough calorie calculation is extremely important, which frequently unfolds that the child is actually taking way above the recommended calorie intake for his or her age and physical activity. Patients outdoor activity, patients non-academic screen time, patients any medication, sleep timing, sleep hygiene, and also the questions regarding the impact of OSA, obstructive sleep apnea, any daytime somnolence, any morning headache, any comorbidities, and also last but not least the mental health of the patient, because it actually goes a bidirectional relationships between the various psychiatric factors can leading to obesity, and obesity in turn can lead to various psychological burden among the patients and also the family. Now, in the clinical examination, as I was discussing, the BMI is very important. There is certain classification of obesity according to the BMI as being shown. Now, it is important that this is has been taken from the Endocrine Society guideline 2017, and it is applicable for children with more than 2 years of age. And they use their CDC chart. In our case, we use IAP chart. Now the problem is that in IAP does not have a chart for 0 to 5 year, 0 to 4 year 11 months of age. They have a chart for 5 to 18 years. So in IAP 2023 recommends that in children between less than 5 years of age, country specific BMI chart are the best to diagnose overweight and obesity. IAP growth charts are not available, as I was saying, for children under the age of 5 years. So what IAP recommends, IAP recommends to use WHO weight for height or length chart to diagnose overweight and obesity in this age group. Now, less than 5 years of age, overweight is defined as weight for length more than equal to 2 SD but less than 3 SD, while obesity is defined as more than equal to 3 SD. For child less than 2 years of age, the cutoff is more than equal to 97.7 percentile. Now, this is the WHO chart for girls. Similarly, boys charts are also available. Now, how the BMI of a child is should be monitored in children under 5 years of 5 years. Weight for length or weight for height plotting should be done at every vaccine visit or at least 6 monthly after his or her first birthday. In children greater than 5 years, BMI plotting should be done at least annually, and those with a more than 85th percentile of BMI should be evaluated for potential comorbidities. Now, BMI के बारे में तो हम लोग बहुत कुछ सुने हैं, लेकिन there are various disadvantages of BMI as well. So in South Asian countries particularly, BMI could not be a good surrogate marker for the true adiposity. For that, a very handy clinical marker is waist circumference. So waist circumference more than 90th percentile has been cut off for has been accepted to identify central adiposity and children who are at risk of developing metabolic syndrome. This cutoff is significantly less in case of Indian children. It is 70th percentile. Now, ये बहुत इंटरेस्टिंग है कि वेस्ट सर्कमफरेंस भी हम लोग जानते थे. Now coming to the wrist circumference. In very busy OPD, you may not get time to check the waist circumference. So in that case, wrist circumference is actually a very good clinical marker for adiposity among the children, and it's normative data among Indian is available, and the cutoff has been proposed that of similar to West circumference, it is more than 70th percentile is a risk marker of metabolic syndrome among Indian children. तो हम लोग ओबेसिटी ओवरवेट थ्रू बीएम एंड वेरियस एंथ्रोमेट्रिक मेजरमेंट हम लोग देखे हैं. नाउ इट इज टाइम फॉर अ जनरल एग्जामिनेशन प्रॉपरली. क्यों हम लोग जनरल एग्जामिनेशन करेंगे? क्योंकि हम लोग ये देखेंगे कि ओबेसिटी के साथ साथ कोई अंडरलाइंग कोई फिजिकल स्टिग्मा है कि नहीं, टू लुक फॉर द सेकेंड क्लू फॉर द सेकेंडरी कॉज ऑफ ओबेसिटी. नंबर सेकेंड इज द adverse health effect of systemic health effects of obesity, like it can be associated with NFLD or NASH, it can be associated with the type diabetes, it can be associated with the various orthopedic problems like SCFE, Blount disease, increased risk of osteoarthritis. Patients may have intertrigo, acanthosis. Patients may have may complain of benign intracranial hypertension. Patient may complain of in that case may complain of headache. Similarly, in case of obstructive sleep apnea, patient may have morning headache along with daytime sleepiness. And now, secondly, the BP should be checked for hypertension, and also the papillary edema must be checked in the head and head, neck, and ENT examination. The eye examination is very important to look for the papillary edema, because edema of the optic disc secondary to increased intracranial pressure in case of BIH. And also tonsil hypertrophy to look for gynecomastia, lipomastia should be looked for. Cervical dorsal hump can occur in simple obesity, but can also occur in Cushing syndrome. And also, you should look for the hepatomegaly for the as a clue for MSLD. And very commonly, parents come with the buried penis in these patients, and proper measurement of the stretched penile length is extremely important to rule out a true micropenis from the pseudo micropenis, that is buried penis. And as I was discussing, the skin in skin acanthosis, hirsutism, very important clinical clue for the early PCO or intertrigo. They are very much skin manifestation of obesity. Now, साथ इसके साथ क्या इंपॉर्टेंट है? The psychological well-being of the child, extremely important. The quality of life, whether he or she is isolated from his peers, whether there is decreased ability to participate in the normal childhood activities, whether the child is subjected to bullying in school or in the playground or in the family as well, and is whether there is lack of social or age appropriate relationship might be a clue for autistic spectrum disorder. This kind of patients has increased risk of anxiety, depression, binge eating disorder, bulimia, etc. Now, how to investigate? Now, investigate एक क्लियर कट गाइडलाइन है कि किसको हम लोग फॉरवर्ड इन्वेस्टिगेशन करेंगे. ये गाइडलाइन है आपका इंडियन एकेडमी ऑफ पेडियाट्रिक्स का. ये क्या बोलते हैं कि ऑल ओबीस चिल्ड्रन मोर देन इक्वल टू 10 years irrespective of risk factors and obese children aged 2 to 10 years with risk factor or waist circumference, just see how much importance they have given to waist circumference, or waist circumference greater than 70th percentile should be evaluated for hypertension, dyslipidemia, MASL or other comorbidities, while all overweight children more than 10 years of age should be evaluated for hypertension, dyslipidemia, diabetes, MASL, etc. in the presence of risk factors or waist circumference more than 70th percentile. Now, sorry, yeah. Now, this is a cutoff for diagnosis of hyperglycemia or diabetes in children. Uh, Second, it is the dyslipidemia. These are being shown because the values are not exactly same as we tend to see in the adult group. So this is very important. Having age defined cutoff for the normal values. And also there is specific cutoff for hypertension and MASLD and metabolic syndrome. The identification of metabolic syndrome is extremely important in this group, and there is separate criteria and pediatric definition of each and every component of metabolic syndrome. Sadly, we cannot diagnose metabolic syndrome according to the IDF definition below 10 years of age, but more than 10 years of age, with these criteria, we should be very aware of metabolic syndrome, and we should diagnose whenever possible. Now, coming to the endocrine evaluation, Endocrine Society recommends against routine laboratory evaluations for endocrine etiologies of pediatric obesity, as discussed, unless the patient's stature or height velocity are attenuated. And also, there is the pediatric obesity is associated with insulin resistance. There is hyperinsulinemia. However, Endocrine Society recommends against measuring serum insulin level in these children. Now, genetic testing. Now, when to do genetic testing for the child? There are three things. First, there is extreme early onset obesity. Early onset defined as before the 5 years of age, and or clinical features of the genetic obesity syndrome, in particular, extreme hyperphagia and family history of extreme obesity. Now, ये particularly important है हम साधारण जनता, इंक्लूडिंग हम लोग के लिए भी जो एंडोक्राइनोलॉजिस्ट है, फिजिशियंस है, पीडियाट्रिशियंस है, एवरीवन, कि ये प्रिवेंशन होना चाहिए एकदम प्राइमोर्डियल लेवल पे. When the mother is planning to have baby, at that point of time, the primordial prevention should starts. That promotion of healthy maternal nutrition and weight status at reproductive age and during pregnancy. Number one. Number second is during pregnancy, there should be proper screening of diabetes, both type 2 diabetes or it may be GDM. Number third, there should be proper infant feeding practice, exclusive breastfeeding till 6 months of age and continue breastfeeding till 2 years of age. Avoid formula feeding. If mother's milk is not available, pasteurized donor milk is better than you use than the formula feeding. Regular meal timing, not to skip breakfast, avoid force feeding, and promote responsive feeding. And this is very, very important, that authoritative parenting should not be done. Rather, authoritarian parenting should be the ideal approach. And now, exercise. There are clear-cut guidelines regarding the exercise. This is taken from the Indian Academy of Pediatrics guideline. For less than 5 years, like infants, they're encouraged to remain active throughout the day. It has been shown that favorable health outcome is associated with 30 minutes per day of prone position in young infants. For toddlers or preschools less than 3 or less than 5 years of age, they should be engaged in varied physical activities as per the developmental stage, and it should be spread across the day. It has been recommended that at least 180 minutes per day of physical activity should be done. And for the more than 5 years of age, outdoor game is should be the priority. Average of at least 60 minutes of moderate to vigorous physical exercise activity spreading throughout the day is recommended, and high intensity interval training or resistance exercise at least 20 minutes per day, at least 3 times a week is recommended. नाउ ये भी बहुत इंपॉर्टेंट है, जो हम लोग पहले डिस्कस कर रहे थे, कि स्क्रीन टाइम বাচ্চাকে আপনি কতক্ষণ মোবাইল বা ল্যাপটপ দেখতে দেবেন। প্রথম কথা হচ্ছে, there is should not be no screen time up to the age of 2 years. It is guideline from the IAP. Maximum 1 hour from 1 to 5 years, maximum 2 hour from 5 to 10 years. 10 to 18 age group is advised to balance the screen time with other age specific developmental goals. The lesser the better. Now, ये हम लोग कम डिस्कस करते हैं कि स्लीप क्यों इंपॉर्टेंट है. The recommended sleep duration by age is 0 to 5 years at least 11 hours, 5 to 10 years at least 10 hours, 10 years and above at least 9 hours. Sleep इसीलिए important है, it sets up the circadian rhythm and also have a very important effect on the HPA axis and the neurometabolism and hypothalamic activity, and particularly if the children is a night owl, there is a very much propensity to have uh, food or frequent snacks during at the time of the night. So that should be prevented. Now, the 5210 rule is a very catchy and very important to remember, that 5 portions of fruits and vegetables, limit the screen time up to 2 hours, 1 hour of moderate to vigorous physical exercise with outdoor games, and zero to sweetened beverages. Now, coming to the treatment. Now, हम लोग एक बच्चा ये हो, क्लास 1 हो, क्लास 2 हो, क्लास 3 ओबेसिटी हो, जो भी है, हम लोग सबसे पहले हम लोग प्रायोरिटाइज करेंगे लाइफस्टाइल मॉडिफिकेशन को. बिना लाइफस्टाइल मॉडिफिकेशन के अलावा हम लोग फार्माकोलॉजिकल थेरेपी के ऊपर हम लोग भरोसा नहीं कर सकते हैं, बिकॉज the thing is that first of all there will be suboptimal response to the medicine if the lifestyle changes are not followed, number 1. Number 2, आप कितना दिन तक, कितना महीना या कितना वर्षों तक देते जाएंगे ये दवाइयां, until and unless your feeding habit, your exercise habit, your behavior is not changed, you the drug actually can do very little. Because आप कितना दिन देंगे, even number 1 is cost, number 2 is कि इसका you are not aware of the side effects of this drug, because there is still not no data regarding the long term administration of these drugs. So how you will promote the lifestyle changes? It should be the intensive health behavior and lifestyle treatment, IHBLT. It should be intensive, it should be age appropriate, it should be culturally sensitive, it should be family centered, it should include dietary, physical activity, and behavioral modification. Now, as obesity is a chronic disease, it should be a longitudinal intervention, proper interaction with the family, with the school teachers, and the child is necessary. It should be a family based, it should be continuous with increased frequency, and the expectation regarding the weight loss with various interventions should be clear from the outset. The start of the treatment should be prompt, should never delay. It should be intensive. It should be empathic, but not stigmatizing. Motivational interviewing is encouraged. The child should be taught about the self management of the feeding, and also the exercise, the self management of the his body weight control, and engagement and participation of the children and his or her parents or close relatives. Now, what are the specific about diet? What are the do's? Timely, regular meal. It is advocated 3 structured meals per day with snacks limited to 1 to 2 per day. Intake of adequate dietary fiber, whole fruits, vegetables, and whole fruits, not the fruit juices, to be encouraged. Adequate water instead of sugar sweetened beverage. Dairy products with low fat should be encouraged. Portion control education is very very important, and also recognize the eating cues in environment, like whether the children takes more feeding while he is watching cartoon, so that should be stopped. The cartoon, the screen time should be avoided while the children is eating. And also the proper leveling of the food, and uh, encourage the single portion packaging. What not to do: avoid constant grazing or frequent snacking, decrease consumption of fast food, decrease added stable sugars, decrease sugar sweetened beverage, avoid high fructose corn syrup, avoid high fat, high sodium processed food, reduce saturated fat. And also, sports or energy drinks should be discouraged. Particularly, school teachers should be educated about this, that the uh, energy drinks should be discouraged in the various school sports event as well. Now, a meal plan can be like this, although it can vary according to the child's activity. But the general is that carbohydrate intake is up to 45 to 65% of total calorie, protein is 10 to 30%, fat is 25 to 35% of the diet. Now, traffic light diet is a very important or very attractive clue what to eat less, and what to eat plenty. and there's online calculator is available to estimate the child's calorie requirement. There are also published data regarding the Indian children's calorie requirement. And but while restricting the diet in obese children, we have to be very cautious that not to make him or her deficient in protein. And also, children with obesity are very prone to develop iron deficiency with or without anemia. So, proper screening of anemia is important, and also the other micronutrient deficiency like vitamin B12, zinc, vitamin D. Now, exercise, as I was discussing, that minimum of 20 minutes of moderate to vigorous physical activity daily with a goal of 60 minutes per day. Actually, IAP advocates 60 minutes per day. Outdoor game is obviously preferred, and limit the non-academic screen time to less than 2 hours as discussed. Now, फैमिली एंड पेरेंटिंग इशू ये बहुत इंपॉर्टेंट है कि देखा गया है कि ये स्टडी में देखा गया है कि ओवर रेस्ट्रिक्टिव पेरेंटिंग एक्चुअली कॉजेज द चिल्ड्रन टू बिंज व्हेन the parents are not in the home or not besides them, and when they have access to unrestricted food. Probe to unhealthy interfamily communication patterns and support rearing patterns that seek to enhance the child's or adolescent's self-esteem. It बहुत important है regarding maintenance of the psychosocial health of the child. Addressing psychosocial health, as I was discussing, that the patients have a impaired quality of life, they have poor self-esteem, may have depression, anxiety, body image dissatisfaction, impulse control disorder in the form of eating disorders, or substance abuse. So very important to evaluate them. Even we are very much prone to use GLP-1 agonist in these children. And before GLP-1 agonist, proper psychosocial comorbidity assessment is extremely important, because in some studies we have seen that GLP-1 agonist can actually increase the risk of suicidal ideation, and we should be very much careful about it. So all obese adolescents should be psychologically screened for presence of mental health issues like school absence, refusal, teasing by peers, persistent anxiety, depressions, self-harm, impulse control in form of uh, anger outburst, or addiction, eating disorder like purging or binge eating. They're very important issue for a holistic management of a childhood obesity. Now coming to pharmacotherapy. So first thing first, this is a quote from the endocrine society guidelines. I'm just reading it out, that they have what are they saying, that we placed a higher value on avoiding drug side effects and on achieving healthy weight through the incorporation of healthy behaviors. The suggestion to minimize the use of pharmacotherapy in children and adolescents reflects the limited efficacy and small number of long-term pediatric trials for existing agents, along with the imperative to manage pediatric obesity as a serious chronic condition in which लॉन्ग टर्म सक्सेस ओवरराइड द शॉर्ट टर्म गेन्स. जो हम बोल रहे थे अब कितना दिन दवाई देंगे, दवाई का साइड इफेक्ट पहले पता नहीं है. ये गाइडलाइन है 2017 का. उस समय तो और दवाइयां और कम थे, उस समय तो GLP-1 एगोनिस्ट उतना मार्केट में आया भी नहीं था. तो दिस होल्ड still it is true, even in the presence of so many drugs being available day by day to control obesity, that pharmacotherapy should not be your first choice. Now, it is recommended only after a formal program of intensive lifestyle modification of at least 6 months. If it is failed to limit the weight gain or to ameliorate comorbidity, you can go to pharmacotherapy along with lifestyle modification. It recommended against using obesity medication who are overweight only but not obese. So for overweight, it is discouraged. It is recommended for older children with severe obesity with more immediate and life-threatening comorbidities. Now, is the IAP guideline, what is they are saying? Adjunct use of pharmacotherapy to a comprehensive lifestyle modification program may be recommended in adolescents of more than equal to 12 years of age having class 2 obesity, that is 120 to 140% of the 95th percentile of BMI, with immediate or life-threatening comorbidities, or class 3 obesity with or without comorbidities. Now, drugs should be discontinued and the patient to be re-evaluated if BMI reduction is less than 5% after taking drugs for 3 months at the full tolerable doses. Now ये कुछ कुछ दवाइयां हम पहले डिस्कस करेंगे जो पहले थे, अभी भी यूज होता है, लेकिन with not that great actually to reduce the body weight, like metformin हम लोग सब जानते हैं. The cardinal status of the metformin is that it is approved in type 2 diabetes patients more than equal to 10 years, and it is not FDA approved for obesity alone, only if it can be given if there is associated other indications to give metformin like PCO, pre-diabetes or diabetes, etc. Now, orlistat BMI reduction is actually very moderate, but it is still FDA approved for the age of more than 12 years. And with high adverse effect, with particularly GI adverse effect due to fat malabsorption, and also high discontinuation rate. We should be very much aware about the associated fat soluble vitamin deficiency due to malabsorption while using orlistat. Phentermine, it is FDA approved as a short course therapy up to 3 months for adolescents who are more than or equal to 16 years of age. Topiramate is actually not FDA approved. The combination is also not FDA approved. I'm not discussing too much. Now, GLP, among GLP-1 agonist, the exenatide, it is approved in children more than 10 years of age with type 2 diabetes. Liraglutide is FDA approved for the long-term treatment of obesity with or without type 2 diabetes in children aged more than equal to 12 years of age. Now, coming to the semaglutide, we are all talking about this. Now, FDA approval has been got that it is US FDA has approved semaglutide 2.4 mg once weekly subcut injection for the treatment of the pediatric obesity, approved from the age of 12 years. Now, this is the trial from which the approval came, that is the step teens trial. It has been shown that you just see the magnificent outcome with semaglutide, that the BMI change and also the improvement in the dyslipidemia and hypertension all are actually statistically significantly improved with the semaglutide group. However, we should be cautious about its GI side effects. And again, without lifestyle modification, this effect will actually not be persistent. Actually, the weight will again come back if the semaglutide is stopped. So, uh, parents or pediatricians or endocrinologists should be very aware that before recommending pharmacotherapeutics, the should be uh, children's behavior regarding feeding and exercise should be ensured. Otherwise, in the long term, these drugs will actually of no use. Now, coming to the some more costlier drugs, but they are actually fantastic drug in the sense that they actually target the key mechanisms in the weight gain, in particularly some monogenic disorders. Like in setmelanotide is approved, FDA approved for use among the patients with 6 years or older with POMC deficiency or PCSK1 deficiency or leptin receptor deficiency, which is should be confirmed by genetic testing. This is actually a MC4R receptor agonist. Um, Also being tried in the Bardet beetle and Alstrom syndrome. Now, another drug, very costly, metronidazole. It is actually not FDA approved for obesity, but it actually FDA approved for treatment of the congenital and acquired lipodystrophy. Now, this actually will works well with those children with monogenic obesity having leptin gene mutation. Somatostatin analog is actually having some good results in some studies in hypothalamic obesity. This is the new molecule in investigational molecule that it actually significant weight loss occurs with loss of fat mass. However, it prevents muscle loss. So actually there is increased lean mass. So as a whole, uh, the bad portion of the BMI, that is excess fat, that is lost, and the muscle mass is not lost. Now coming to the bariatric surgery. Bariatric surgery, I will not go to the too much of detail. Uh, the bariatric surgery is indicated only in those children with the class 2 obesity with comorbidity or class 3 obesity without comorbidity. And it is preferred that the children attains at least in a stage 4 or 5 before bariatric surgery is planned. However, nowadays this contraindication has gone away, and there are multiple reports successful surgery being done even in the prepubertal children as well. However, we should be very much aware of the fact that uh, pediatric surgery should not be encouraged, should not be indicated in patients with known psychiatric morbidity. So, the most common form of pediatric surgery here is the we use is sleeve gastrectomy or Roux-en-Y. And this is a prospective study, a teen lab study which has shown the effectiveness and the safety of bariatric surgery among pediatric age group. We've Now I am just concluding my remarks. Key takeaways. I am talking it in Bengali for the sake of the patient for patients or doctors from the West Bengal or Tripura region or Assam region or even Bangladesh. যে সব থেকে common cause of obesity in adolescents or in even pediatric age group is exogenous. Simple. মানে সমস্যা কোথায়? ডায়েটে বা এক্সারসাইজে বা দুটোতেই। ঠিক আছে? কিন্তু সবসময় মনে রাখতে হবে যে যে কোনো ক্লিনিক্যাল ক্লু যেগুলো আমাদের আমাদের পয়েন্ট করে, ক্লিনিক্যাল পয়েন্টার টু রুল আউট দ্য এন্ডোজিনাস কজেস অফ ওবেসিটি, সেগুলো আমাদের মাথায় রাখতে হবে সবসময়, কিন্তু খুবই আনকমন স্টিল, পার্টিকুলারলি ফর এন্ডোক্রিনোলজিস্ট, childhood obesity with short stature should be thoroughly investigated for underlying endocrine cause. Early, intensive, multi-component, multi-dimensional treatment should be encouraged. Only pharmacotherapy is not the solution. বারবার যেটা বলছি যে শুধু শুধু ড্রাগ দিয়ে কিন্তু চাইল্ডহুড ওবেসিটি কমব্যাট করা যাবে না। ড্রাগ দিয়ে যতটা অ্যাডাল্ট ওবেসিটি যতটা ইউজফুল হবে, শুধু কিন্তু চিলড্রেনদের জন্য কিন্তু ড্রাগ দিয়ে হবে না। রাদার IHBLT, the lifestyle modification is way more important than the pharmacological therapy. And monitoring should be lifelong. As in any other chronic disease, monitoring should be lifelong. So here I conclude my presentation and uh, hand over to the organizers for further proceedings.
Thank you so much, Dr. Subhankar. A great presentation, and lots of questions coming up for you. Some you have answered in the course of your talk. कईयों के तो जवाब डॉक्टर साहब ने दे दिए हैं, पर वो दोबारा लेते हैं. तो सर, एक तो गुड इवनिंग है from one of our youngest pediatricians. He has 76 years experience of being young, and Dr. R.S. Pawar sir from Saharanpur in Western UP sends you his blessings. Aditya Pannu, who has full 18 years experience of being young. He's a smart, dashing boy from Haryana. He says namaskar to you. Pratibha Chopra ji, Dr. Yogesh Uplenchwar, Saroj Agarwal madam, सब आपको greet कर रहे हैं. And Dr. Subhankar, Aditya Pannu says, sir, I have been able to overcome my diabetes with diet and with exercise. But question is, can people with diabetes take vitamin C, chewable tablets? So what are the indications for vitamin C in today's world, and can people with diabetes take them?
Yeah, vitamin C is actually is a great vitamin molecule, particularly due to its great antioxidant property. However, the unrestricted use of vitamin C is should not be promoted, and as far as my knowledge goes, sir. And actually, the effect of there has been studies or meta-analysis regarding the use of vitamin C supplementation. So there are all their short-term studies. However, vitamin C supplementation may improve actually glycemic control and BP in people with type 2 diabetes. However, these studies are not that much confirmatory that you can recommend vitamin C supplementation for life to combat against diabetes. But yes, sir, vitamin C has a great antioxidant property and should be encouraged. But I don't think daily vitamin C intake in the form of tablets should not be encouraged. Rather, take it with as a part of those fruits which are rich in vitamin C. That is much more better option for vitamin C. Actually, craze for vitamin C sell a lot after initiation of COVID. People were eating vitamin C right and left, but that should not be very scientific, I think, sir. What
And
is your
another
take,
question,
sir?
yeah, another question related to this. ऐसी कोई पुरानी ग्लूकोज मॉनिटरिंग टेक्निक्स हैं जहां पे अगर आप विटामिन सी बहुत ज्यादा लें तो शुगर के नंबर में इम्पैक्ट आ सकता है? एंड इज दैट रेलेवेंट फॉर मोस्ट पीपल टुडे? Can vitamin C interfere with the
Yes, sir.
glucose
Yes, sir.
monitoring?
Definitely, definitely. Because sir, it is an antioxidant. So it actually those with God pod methods, we used to use or use in if you in ancient times, Benedict Regent, they actually have a similar cross reaction with glucose. So that will give mismatched values or even higher values in Benedict tests. So that should be discouraged. Yeah.
So that's also important. आप एक बार चेक कर लें अपने डॉक्टर से, अपने लैब वाले कलीग से कि वो आपकी शुगर किस तरह से चेक की जा रही है. कई बार विटामिन सी के साथ फॉल्ट पॉजिटिव आता है. One question from Dr. Manzoor Raina. Sir, we are aware of various types of hormones. So we have got happy hormones and we have got angry hormones also, or maybe you can call them affable. Affable means friendly hormones and antagonistic hormones. These affable and antagonistic hormones keep on fighting each other. एक जैसे कौरव पांडव की लड़ाई चलती रहती है तो खुश हार्मोन, खुश मिजाज हार्मोन भी हैं और गुस्सैल हार्मोन भी हैं. तो let's take this picture now, the happy and the angry hormones. So first is when there was a fight between the Pandavas and the Kauravas, there were very few Pandavas, many Kauravas. Similarly, let us say there is one insulin, but there are many counter-regulatory hormones. Is the same concept true in obesity? Then Dr. Manzoor comes to his specific question. Leptin, interleukin 6, TNF alpha, ये सब angry hormones है ना, the fighting kind of hormones. Adiponectin, this is a happy hormone. Ferritin, sometimes happy, sometimes bad. दोनों तरफ जा सकता है, it can go to both sides of the warring camps. So, what is the role of all these hormones in the development of obesity and diseases like fatty liver?
सर ये तो आज प्रूव है कि ओबेसिटी इज अ chronic inflammatory disorder. In obesity there is chronic inflammation going on in your body, and adipocytes are no more just a neutral fat cell. They are actually a separate endocrine system themselves, and which secrete a lot of good things as well and bad things as well. Among the bad things, TNF alpha, IL-6, these are can all be released from the fat, particularly visceral fats. So inflammation is a first of all uh, ad, adipopathy or being fat is a chronic inflammatory condition, number one, leading to release of plethora of inflammatory markers, that ultimately leading to insulin resistance. So insulin cannot act peripherally. That all these things actually lead to type 2 diabetes, be it hypertension, be it your fatty liver. They are actually under the umbrella of a same problem, insulin resistance. So adiposopathy should be combat against by reducing your fat but not muscles. So as I was talking, you should preserve your muscle, reduce the whole body weight by reducing your fat but conserving your muscle, number one. Then it will lead to decreased inflammation, leading to again your the reversal of the insulin resistance, and also the reversal of the, or at least some remission of the diabetes, or reversal of the early fatty liver, or reduction of the hypertension.
So the point well taken. And so apart from what Dr. Manzoor Rana has said, it's not just about pathogenesis, it's also about treatment. You can actually use this understanding to promote proactive treatment and prevention of all these diseases like obesity and MASLD. So thanks, Dr. Rana, for pointing this out. And this concept of the Kauravas and Pandavas, or perhaps happy hormones and hateful hormones, or maybe affable versus antagonistic hormones, whatever comes to your mind, you can use it with your patients and you can explain to them. We don't need to remember all the names also. It's enough to remember good and bad hormones, and you need to increase the strength of the good hormones while reducing the functionality of the bad ones. Inflammation is also important, like TNF alpha interleukin 6. You can explain to the patient कि ये जो fat है, ये inert नहीं है. It secretes
Yes.
poisons or toxins or hormones which actually impact the entire body. Speaking of the entire body, Dr. Shivlata Chatwal madam says that sometimes we have children who are actually very keen on losing weight or maintaining weight, but they just cannot stop their craving for food. It's like an addiction. So, any drugs that we can use in the short term in children for a few weeks to help them stop, reduce their appetite.
Sir, as I have said that only phentermine has been approved for a short-term use, like for 3 months, like these kind of things. But main thing is their behavioral modification, patient-centric, family-centric counseling, and important is motivational interviewing. If not just saying that you have to do it, but you should incorporate the child into your decision making pathway. That's why children are not are very much intelligent, sir. They can understand if you talk in their language, that why it is important, and why they have to lose weight, that not just for now, not just for looking well now, but for a long term benefit.
Yeah. So, explain to
However,
children.
sir, for short term management of hunger, sir, I don't think anything like GLP-1 or something. These medications should not be promoted. Rather, there is enough chance that this will be missed as an over-the-counter drugs, or like various fat diets or exercise. So uh, I don't think that to lose weight, any immediate decision making regarding drugs should not be made.
That point is well taken. In adults, you may wish to use topiramate for a few weeks up
Yeah.
till 8 weeks to reduce appetite. Actually, topiramate ज़्यादा use किया जाता है by our colleagues in pediatrics for pediatric seizure disorders. But जो भी ऐसी
Yes.
दवाई लें, मतलब एक स्पेशलिस्ट के साथ लें, अलग से ना लें, और अपना ख्याल रखें. Keep on monitoring yourself. Finally, focus will be on lifestyle modification, क्योंकि वही चीज़ आपके साथ रहने लगी है throughout life. This Dr. Subhankar has reinforced again and again, and जितना ज़्यादा
Yes,
इसको
sir.
reinforce करें उतना कम है.
Yes, sir.
And
Yes, sir.
Dr. Subhankar,
Definitely.
it's been great being with you. एक घंटा हो गया और हमें पता ही नहीं चला. We didn't realize. And so
And
many questions.
I have been pretty lengthy, sir. Sorry for that, but I had to cover at least touch upon few things. Sorry, sir.
Yeah. No, but it is really important because this is what we need. And अगर हम अपने देश की दुनिया की सेहत बनाए रखना चाहते हैं for the next generation, we have to focus on it right now.
Yes, sir.
Dr. Subhankar, you will be so pleased to see Swapna Jain madam from Vellore. She has created a mnemonic for you, which you can remember and you can teach your patients. Children is chill plus run. So if children run, if they chill out and if they run, they will be healthy children. Chill
Yes,
means
definitely.
healthy mind habits, be happy, must raho. Run means active body habits. So mind habits and body habits. तो स्वप्ना जैन मैडम कहते हैं कि जैसे हम बात करते हैं लाइफस्टाइल की, we should also talk about mind style. Don't
Yes.
say mindset. आप माइंड स्टाइल की बात करें तो बच्चों का और बड़ों का हमारा भी अपना लाइफस्टाइल भी सेहतमंद रखें, और माइंड स्टाइल जो दिमाग का स्टाइल है उसको भी सेहतमंद और सात्विक रखें. So thank you, Sapna madam, for putting across this very cool thing, chill plus run.
Thanks, madam. Thanks, madam. Yeah.
We have Arpita with us backstage. Arpita, could you please show a certificate of appreciation for Dr. Chatterjee? In the meanwhile, Dr. Subhankar, anything you'd like to say, a conclusion? Thank you so much, Arpita, and thank you, Dr. Subhankar. Anything
Thank
you'd
you.
like to say, a single sentence, and our topic is childhood obesity. Thank you, Arpita.
Sir, children should be made free to live their lives in terms of playing, enjoying the outdoor games, and eating healthy. And with an, as you said, uh, mind style, with intact mind style.
एंड विद दिस फ्रॉम रामजी अग्रवाल साहब, सबकी तरफ से बोल रहे हैं धन्यवाद. धन्यवाद, शुक्रिया,
धन्यवाद सर.
मेहरबानी, थारा भला हो, एंड धन्यवाद इन बंगाली, एंड जय हिंद डॉक्टर
धन्यवाद.
सुभांकर.
प्रणाम सर.